I do think that capitalism, does probably breed a lot of mental health problems because it's competitive, it's ruthless.
What is the easiest way that a patient can understand or might, feel that they need to go and talk with a psychologist or a psychiatrist because they might have OCD?
So people with OCD, they suffer from repetitive, so recurring, unwanted, intrusive thoughts or images or urges and sometimes doubts.
So hello everyone, I have a very exciting guest today, Dr. Oliver, a clinical psychologist and clinical director at Intellect, which is a Singapore-based modern-day mental health care service provider and ecosystem builder on mental health. And I met Dr. Oliver a couple of months back in Singapore, and we had a fantastic meeting. And then now I'm so happy to welcome Dr. Oliver in my podcast. So Dr. Oliver, currently, apart from being a part of Intellect as a clinical director, he is also faculty in National University of Singapore as in the clinical psychology department, and he's an active researcher on mental health. And we'll talk about modern day challenges of mental health, OCD, and challenges that psychologists face when they are doing counseling and all of that. So I'm very excited about it. But let's start with one bit. So originally Dr. Oliver is from Germany, and then now he's based in Singapore. He has a very exciting profile. Why do you think, Dr. Oliver, that overall, globally, mental health struggles, depression, anxiety, suicide is increasing the way it's increasing? It's if a country like Sweden, who's really struggling to prevent suicide, even in Bangladesh, suicide is increasing. Singapore, everywhere, mental health problems are increasing. Why do you think that mental health problems are increasing? What are the underlying causes?
The great work you do in Bangladesh as well contributes to people understanding mental health struggles more. And so with people being more educated, they are also more forthcoming. So they speak to their doctors or they speak to their families more about their struggles. Of course, there's a lot of work we need to do, but generally that's the trend, that we understand mental health problems better, we talk more about them. Our doctors and psychologists and counselors have a better understanding. They're improving on assessing mental health as well, so they pick up more in our primary care services, for example, general practitioners. Develop a better understanding and so on. So all of those improvements in terms of our understanding and the improved awareness, I think, leads to the seemingly increases of mental health problems. So in other words, it's perhaps not a real increase, it's more we're just getting better at identifying it. However, I do think there are some reasons as well that may explain why we also see higher rates, and of course, the COVID-19 pandemic plays a big role here. It's a little hard to get so-called causal data. So to be absolutely sure that, say, the pandemic actually caused mental health problems to go up. But we have longitudinal data and cross-sectional data now that shows very clearly that there is a link between stress around COVID-19, all the restrictive measures government have implemented around the world and now starting to release as well, have led to an increase. We'll talk more about obsessive compulsive disorder later, but there's good reasons to think that people have become more compulsive around their checks, their washing, and so on, out of a fear of catching viruses and so on. And of course, many people have lost their jobs or had to adapt to the new job situations around the world. And that has created a lot of stress and has likely also led to family problems where people had to work from home, not having the space, perhaps that is conducive to working from home very well. And so it looks like that the pandemic actually has accelerated the problem. But at the same time, it has also helped us to become more aware of mental health struggles. So perhaps that's the only good thing that's come out of the pandemic, if anything.
So what are the underlying social causes in modern times that you feel that is counterproductive for mental health or psychological well-being?
Can you share more about what you mean by the social causes?
For example, digitalization, right? For example, hyper neo-capitalism. For example, philosophies of life. How our teenagers are driven to different instincts, and how it is being popularized, and how does that, or if any, contribute to increased mental health problems or psychological struggles?
Yeah, that's a really great question as well. And I don't have definite answers, but I can speculate a little bit with you here. I do think that capitalism, does probably breed a lot of mental health problems because it's competitive, it's ruthless, it has often a winner takes it all kind of attitude, and it creates anxiety because people compete about jobs and salaries and promotions. And many countries around the world don't have good employment laws. They don't protect workers very well, so there's always a fear I can lose my job if the economy isn't doing very well. We have very high inflation around the world, which creates a lot of anxiety, people losing a lot of money just due to inflation, and that creates financial stress. So I do think that capitalism really is probably not very conducive to good mental health, especially if there's no good social welfare laws in place that protect workers. And the other aspect you had referenced is digitalization. I do also believe that spending too much time, especially younger people, on their phones and in front of screens, and can really disrupt our attention. It can interfere with our sleep hygiene if we can't come off the phone so late at night. And we know that sleep is an extremely important factor in our well-being. If we don't sleep very well, that is most certainly going to affect our well-being. So anything that interferes with our healthy sleep habits or healthy eating or exercising is likely not going to be very helpful, and probably increases mental health problems.
Right. Absolutely. Let's dig deeper on particularly obsessive compulsive disorder. I've clearly seen that you have done a lot of work, both research and clinical, on OCD, and we see a lot of patients suffering with OCD. But unfortunately, I don't see enough of psychoeducation related to OCD for patients. So let's start brick by brick. So first of all, what is the easiest way that a patient can understand or might feel that they need to go and talk with a psychologist or a psychiatrist because they might have OCD? What is OCD, and how can a layman understand that he might be a patient or client of OCD?
Okay. Yeah. Okay. So first of all, what is OCD? So OCD stands for Obsessive Compulsive Disorder, and it is one of the most common mental health problems around the world. Globally, it ranks number 4. And here in Singapore, where I am based, for example, it's the 3rd most common mental health problem.
Wow.
I'm not sure about the prevalence rates in Bangladesh, but I think around 2. I have seen a study that puts it at 2 to 3% amongst young people in Bangladesh as well. So
definitely among top 5 mental health disorders in Bangladesh. Definitely.
Right. So these numbers may not sound very much, 2-3%, but if you think about it on a population level, there's how many people are living in Bangladesh? 150 million or more, right?
180 million plus. Yeah.
180 million. I mean, we're talking huge numbers here. Many people being affected. So what is OCD then? So first, there are obsessions. So people with OCD, they suffer from repetitive, so recurring, unwanted, intrusive thoughts or images or urges, and sometimes doubts. Are what we call ego dystonic. That means the person does not want to have those thoughts. They have random thoughts that they feel are unpleasant, distressing, and causing them a lot of distress. And they respond to those obsessions with compulsive behaviors, which are repetitive behaviors or mental acts that the person performs in order to either remove the obsession or neutralize it or avert any harm they fear might occur as a result of it. So they're trying to prevent harm by undoing whatever thoughts they have. And in order to qualify for a diagnosis of OCD, the person needs to experience those obsessions and compulsions for a minimum of 1 hour per day, roughly. And they also need to be distressing, so time-consuming and distressing. This is often a very good gauge for lay people if they want to understand better whether the thoughts they experience warrant some help. So if you are distressed by your thoughts, if you feel your thoughts and your compulsive behaviors, they get in the way of you doing your jobs or doing your family chores, or if they interfere with your relationships, it's probably a very, very good idea to go and see a psychiatrist or a psychologist. Typical thoughts people, obsessive thoughts experience, they can, really a broad range. Right. They tend to fall into kind of 4 categories. First of all, contamination fears. Many people are worried about germs and viruses and so on. That's one big category. The other one is unacceptable thoughts. So people having either religious thoughts they don't want to have, or sexual thoughts, or violent thoughts that causes them a lot of distress, and they feel they have to neutralize that.
This podcast episode is sponsored by FoodnFlavours. FoodnFlavours না থাকলে আমি জানতামই না যে আমিও অসাধারণ রান্না করতে পারি। আমার কখনোই রান্না করা হয়নি এবং FoodnFlavours আমার মতো ব্যস্ত মানুষদের জন্য এমন একটা মিল কিট নিয়ে এসেছে যে মিল কিটে সব কিছু ফ্রেশ, অর্গানিক এবং আমি উইদিন 10 to 20 মিনিটসে আমার বিজি লাইফের মধ্যে কিন্তু আমি কুক করতে পারছি। আইটেমগুলো আপনারা ট্রাই করতে পারেন। আই এম শিওর ইউ উইল লাভ ইট। নিচের লিঙ্কটা ক্লিক করবেন আরও ডিটেলসের জন্য।
The other category is inflated responsibility. So many people with OCD, they have thoughts and they think they're responsible for preventing harm. So, for example, then they may think if I don't have the correct thought in my head, something will happen to my family, so I must have the correct thought. And then they try and go back in their thinking, or they cross the street and they have an image of, say, an accident happening. And then they have to undo that image in order to prevent any accidents from happening. So magical thoughts, we sometimes call this, where you think that your thought can cause something to happen. And the fourth category is symmetry. Many people with OCD also, they have obsessions around symmetry or things being incomplete or not right. So, for example, on their desk, they have to arrange things in a particular order until it feels right. Or they have to walk in a particular way, counting their steps, perhaps, until it feels right. And yeah, you can see it's really a very, very broad range. But the common theme that cuts across all those different types of thoughts is usually that the person fears there are consequences, harmful consequences, either to themselves or other people, if they don't act on those thoughts. So people with OCD, they usually can't just dismiss their thoughts. They feel they have to act on them. And that's where the problem starts, because they get drawn into their obsessive thinking, and it's very hard for them to break out of that.
So if someone has OCD, should they first visit a psychiatrist or a psychologist?
It doesn't really matter. So I think any good psychiatrist or psychologist, they should be trained in identifying clinical psychologists, I should say. Here in Singapore, psychologist usually refers to someone who has an undergrad degree in psychology, and so they're not trained to assess and diagnose. You need clinical psychology training, which should be at the master level. So following your undergrad training, you should have at least 2 more years, if not 3 or more, of specialized training that allows you to be a proper mental health practitioner. So you can go to a clinical psychologist or a psychiatrist. Either should be able to assess you properly and establish whether you have a diagnosis or not.
Right. What about when sometimes what we see in Bangladesh is that OCD patients, either they're going to only psychiatrist and taking medicines for quite a long period of time, or they are only visiting counseling because they don't like medicines. They have, bad, idea or thoughts about, fears about psychiatric medicine. So what is the importance of having both in severe OCD?
So psychiatrists are medical doctors, right? They're medical doctors, and they treat OCD or any other mental health problem predominantly by prescribing medication, whereas a clinical psychologist or a cognitive behavior therapist, they treat patients via talking treatments, where they try and understand the thinking and the behaviors and help the person that way. So we can follow the recommendations, the treatment recommendations, such as the UK NICE, so-called NICE guidelines, and they recommend that for mild OCD, so when the distress level falls in the mild range, so that these are people who can maybe still go about their jobs, they can still function to some extent. There's some suffering, but it's in the mild range. They don't need to take medication. Typically, it's not recommended. They can engage in self-care tools. For example, Intellect, right? You mentioned earlier, we are modern mental health technology companies, so we offer evidence-based self-care features where you don't have to see a psychiatrist or psychologist. You can work on improving your mental well-being through daily exercises that helps you to identify unhelpful thinking patterns, or that helps you with meditation, or that helps you with other good well-being practices for the mild range. If you have moderately severe OCD, the recommendation is that you can choose between medication, so-called SSRIs, or a cognitive behavioral therapy, which is the treatment of choice, psychological treatment of choice for OCD, and has the best outcomes. And for very severe OCD, so people who perhaps can't leave their house because they get stuck in their head, they have to ritualize, and it's just not possible to function properly. Often a combination of medication and CBT is the way to go, because the medication may help the person to engage in therapy. But I would say that a good starting point, actually, you said many people don't want to take medication, is actually psychology or CBT. Because from the research data we have, we know that once you're on psychiatric medication, especially SSRIs, you often need to take them for a minimum of 6 months or longer because of side effects. You can't just discontinue. And often when people with OCD stop their medication, the symptoms tend to come back. Whereas if you successfully complete a course of specialized CBT for OCD, the relapse rates are much lower. So actually the long-term outcomes are much better if you manage to complete CBT for OCD.
True. What we have seen in our centers is, in terms of outcome, the best outcome came in for severe OCD cases is when there was a nice combination of, I would say, optimal dose of SSRI and proper cognitive behavior therapy for OCD. That combination worked the best in severe OCD, right? Those patients who were given only psychiatric prescription and no cognitive behavior therapy or no counseling rarely recovered overall. There are, in mild cases, definitely only through CBT we have seen patients recover. So I completely agree with you. Let's dig deeper on the thoughts aspect. Because in Bangladesh, what we have seen is that people suffer mostly with thought-related OCD, and they don't understand that it is OCD.
Right.
So, sorry, Dr. Oliver, can we take just a 30-second break from the podcast and then we return? One thing that my creative team is saying is that, can we just change the background to the straight one that we started with no background? Because Without a background. Yeah.
Yeah, no problem. Go to settings. Okay, 1 second. The blur background, this one.
No background.
No blur?
No blur.
No blur.
Just the straight one we started with.
Yeah, okay, sure.
Excellent. Yep. Yeah. So
No
let's resume where we were.
You said that you agreed with me
So
the treatment, a combination of medication and therapy for the more severe ones, but you found that if they only take the meds, usually the outcome's not very good.
Yep. So what we see, Dr. Oliver, in Bangladesh is that people don't understand that they're suffering from OCD when the OCD is related to their thoughts or religious thoughts or sexual thoughts. So people only think that it's OCD when they're washing their hands way more than they should. That's what they only consider to be OCD. But they don't understand when they are having, recurring sexual thought and they cannot stop it for no good reason, their thoughts are just coming, or they are having unwanted religious thoughts about God, about prophets, about anything sacred, and they're thinking, they're having filthy thoughts about it. And they don't understand that this is OCD, but they're suffering severely. And from that suffering, sometimes they become psychotic, or there's early symptoms of schizophrenia. Sometimes they become major depressive disorder. So can you explain a bit more about, in your experience, what are this category of having inappropriate thoughts?
So this is a really good question, and we see this around the world, here in Singapore and other countries. So I'm not surprised to hear that this is the case in Bangladesh. So basically, right, we all have, every single human being has unwanted thoughts. We all get them. It's just part of being human. The way our minds work is that we can't control all our thoughts. It's just not possible. We can have maybe some control through meditative or religious practice, perhaps, but generally the way humans, the human mind works, we can't control all our thoughts. We have a lot of random thoughts, many of them being inappropriate or of sexual nature, religious or violent nature. So that's a really important starting point to understand how to help people with OCD, especially when it's in the unacceptable thought category, right? So these thoughts are normal and they just happen around the clock. But we have some control and choice over whether we want to zoom in on those thoughts and elaborate further on them. So therefore, it is important to understand what is OCD and what isn't. Because if it's OCD, you don't want to encourage clients or people to zoom in on those and ruminate more and become trying to work out how to stop those thoughts. That's not going to work. It's like one of the interesting experiments we often do in therapy is if you try not to think of a pink elephant, right? And you must try very hard not to think of a pink elephant. Of course, you're going to think of a pink elephant. It's just, you can't switch off thoughts like that. So that is a very important understanding. So people with OCD, who suffer from OCD, they misinterpret those unacceptable thoughts as more meaningful than they really are. And they feel responsible to neutralize those thoughts or undo them or counter them with prayers or other possibly compulsive practices, right? So a good starting point is to ask yourself, am I trying to control my thoughts? If the answer is yes, perhaps that is an indication that this is not the right way to deal with the thoughts, and maybe it's OCD. Secondly, are you distressed by those thoughts? Do you wish not to have them? And are you trying to get rid of them because they're causing you some form of distress or discomfort? Again, if the answer is yes, it may very well be OCD. And in therapy, you learn to not engage with those thoughts. You learn that you are perfectly safe without doing the compulsive rituals or compulsive behaviors or compulsive mental acts that you feel compelled to do. And then patients or clients can experience that they can actually tolerate having those thoughts without the need to act on them.
Right.
So that's a very good starting point to first understand that we all have those thoughts, and the more you try and control them, the more you have them.
Clients very often have this question about, should I do thought challenge or should I not challenge those thoughts? And if I do challenge those thoughts, what is the starting point?
So I think this question is best addressed probably in therapy, where you can be guided by someone who has experience in treating OCD. Because one of the main things you do in therapy, in cognitive behavior therapy, you do exposure treatment. More precisely, you do exposure and response prevention. So you expose yourself to the distressing thoughts on purpose. And you learn not to react to those thoughts in a compulsive way. And then you need to disengage from those thoughts and just not pay attention to them, and just, go about your day and not... Oh, I think I just lost... Are you still here?
Yes, I am.
Sorry, the WhatsApp.
No problem. All right. No problem.
We have to probably edit that later.
No problem. We'll do that.
So yeah, a psychologist can help you to reframe those thoughts as they're just normal. You don't have to act on them. They may be distressing, but you don't have to react compulsively. And then you learn not to pay attention to them and ignore them as much as possible, really.
Great. Yeah, so I think that it's difficult for patients to do the thought challenge by themselves. It's easier for them to do it with a therapist. Yeah. So
exactly.
Yeah.
And especially,
sometimes when patients try to do the thought challenge by themselves, they actually make it worse.
Yeah. And it is confusing, right? Especially if the obsessions concern purity and sort of more moral, what we call moral contamination. If you feel polluted or contaminated from the inside because you feel you offended your God and you are you're not a good Muslim or Christian or Hindu, that can cause immense suffering. And it's usually better to work with a psychologist who is culturally trained, who understands your religion, and who can work with you in a very culturally sensitive way, because the lines can be a little bit blurred between what should I be doing according to my religious practices and what should I be doing in therapy to overcome the OCD.
Yeah, that's a very important point, because in Bangladesh, what we clearly see is that sometimes when religious people have OCD, they believe it's not a psychological problem, it's a spiritual disease of the heart, because they're impure, so their impure thoughts are coming, and they want to become pure through their rituals and religious practices, and it becomes worse and worse because they are not taking treatment, and they think that they are doing all the pure things and having all the impure thoughts, and it makes them super depressed and even sometimes suicidal, because they feel that God has completely forgotten them or abandoned them, and it's just a chaos in the head, like completely, so that is where that the discussion of OCD in Bangladesh is more important.
So I agree. And personally, when I work with Muslim clients or Christian clients who had OCD, and where the OCD is centered around blasphemous thoughts or having inappropriate religious kind of thoughts, and they felt compelled to do excessive praying and purity rituals and so on. One thing that I found very helpful, and I really think is a good idea, is to work with spiritual leaders as well, who understand mental health, who you can involve in the treatment process, to help the client to get some clarity. What is appropriate? What is an appropriate religious practice that is non-OCD, and what is really clearly OCD? And that distinction, can sometimes be a little bit difficult to make, but with the right help, especially if you get help from a spiritual person who you respect and you feel you can work with, and that person also needs to understand mental health, right, to help you distinguish the religious aspect that is, very appropriate and healthy, and the part that is more the mental health problem. But as a rule of thumb, I would say, if your thoughts are to do with blasphemous thoughts and you feel there's immense suffering and you feel very compelled to do excessive compulsive praying or other religious rituals, ask yourself, does this go beyond what perhaps other people in your community would do? Because even though mental health problems are very, very common, the majority of people, whether they're religious or not religious, or have a different religion, they don't have OCD. So OCD is not the norm. It's still a mental health problem. And if you suffer from OCD, you need to get professional help, especially when it's more than mild. I said earlier, if it's in the milder category, yes, you can do some self-care features. But if you are really experiencing distress and some impairments, it's really best to reach out for help.
One of the interesting thing that we are doing from LifeSpring is that we are creating a free psychological well-being training for Muslim spiritual leaders. So it's just a free training that they can do, and a big part on that is psychotic disorders, including OCD, because in Bangladesh the tradition is for the vast majority of people is when they have a psychological problem, they go to the spiritual leaders. This podcast episode is sponsored by FoodnFlavours. FoodnFlavours না থাকলে আমি জানতামই না যে আমিও অসাধারণ রান্না করতে পারি। আমার কখনোই রান্না করা হয়নি, এবং FoodnFlavours আমার মতো ব্যস্ত মানুষদের জন্য এমন একটা মিল কিট নিয়ে এসছে যে মিল কিটে সব কিছু ফ্রেশ, অর্গানিক, এবং আমি উইদিন 10 to 20 মিনিটসে আমার বিজি লাইফের মধ্যে কিন্তু আমি কুক করতে পারছি। আইটেমগুলো আপনারা ট্রাই করতে পারেন। আই এম শিওর ইউ উইল লাভ ইট। নিচের লিঙ্কটা ক্লিক করবেন আরও ডিটেলসের জন্য। But the spiritual leaders doesn't have any introduction to mental health. So, and they try to, solve every problem through their healing approach, like from religious scriptures. And it's not, I'm not blaming them in any way. They're just innocent and they just don't know about it. So we want to educate them about, definitely there are spiritual aspects or spiritual moral code, but there's also a mental health umbrella and mental health disorders. So it's completely free that we are creating. Any imam or any, Islamic spiritual leader can just do it for free. And it's just to educate them. And I think that it's important because so many people really suffer.
Fantastic. It's a really wonderful initiative. That's really, really wonderful. I'd love to hear how that's going. Because I think, especially in Bangladesh, right, where I think it's 90%, roughly 90% of the population.
85%, yeah.
Or 85%. So the vast majority. And so it is important that spiritual leaders understand mental health problems and can work with mental health professionals together to help those in need. Very, very important.
Yeah, absolutely. So let's talk about why is it so important to get the context right for the therapist or for the psychologist, to know the culture, the context. Why is it important to go a community-based mental health care approach? In your experience, why do you think that's important?
So, because when we're talking about mental health, right, we need to understand how the problem. Two things. We need to understand how the problem developed in the first place and how it is maintained. That's typically those two questions are, the psychologist or the therapist, they try to answer. And the cultural aspect, the community where we grew up in, the practices we're exposed to from young play a very, very important role in our understanding how mental health problems manifest for some. For most mental health problems, it's a combination of some perhaps biological factors, psychological factors, and the way we are raised in our families, and the community aspects as well play into this as well. So to give this a bit more color, so for example, in Singapore, OCD rates are very, very high, much higher than in the rest of the world. And we don't know exactly why that is, but we can make some educated guesses. So it's a very competitive society. Children from very young, they learn that grades are one of the most important things. They compete with each other and they become very perfectionistic. Young children become very perfectionistic in school because they want to do very well. So perfectionism seems to be culturally rewarded in some way, because if you're perfectionistic, you perhaps do better in school. And then, but a byproduct, I'm speculating here, but this is an educated guess, is then that you become, more compulsive. You become more rigid in your thinking, and then this may help you for your math exam or, for your studies. But if you apply the same perfectionism to your thoughts, we spoke about controlling your thoughts earlier as counterproductive. But if you try to use the same perfectionism and rigidity to control your thoughts, you're making mental health problems more likely. So that's why understanding the cultural aspect is very important. And so it's similar for religious practices, right? I would say it's perhaps for the psychologist more important as well how each family, like the clients, the patient's family, what were the values in that family? How were certain things practiced? What was rewarded or punished from young? Because young children, they learn very early on what is right, what is wrong. They copy, they mimic their parents, and they may learn that certain practices are correct or not. And another example is if you brought the example of hand washing earlier. If cleanliness or purity are highly valued in the home, then the chances are that the young person learns from the parents that they must always be clean are very high. Or if the child observes the father, maybe calling a member from another race, say, dirty, hopefully that doesn't happen, but, the reality is probably does happen. They internalize it and they learn that certain things are pure, not pure, and they learn from their parents. So that's why we need to understand the the family context. But of course, it does help if the therapist has a very deep cultural understanding, because they can relate to the religious practices and other spiritual practices better. But even if the therapist has the same spiritual or religious background, you should never assume as a therapist that you fully understand your client. You should always keep an open mind. You should learn about the practices of your patient. You should be respectful, of course, and really try and put yourself in your client's shoes. But of course, if you have a similar background to the patient, it may help with trust as well. So the patient may trust the therapist more if they perceive you to be, to have a similar background. That is, of course, very helpful.
Right. Also, it's easier to have a heart-to-heart conversation, when you are from a similar context. It's because when you are going to a dentist, you don't need to have a heart-to-heart conversation. But when you are going to a therapist, you need to have a open-ended heart-to-heart conversation. So
absolutely true. Yeah.
So that's
But for those reasons, I think because the trust in therapy is one of the most important things, that you can build a good, what we call therapeutic relationship with your therapist or doctor is very, very critical. That on its own explains a lot of positive change in therapy. If you trust your therapist, if you feel understood by your therapist, that alone helps a lot of people to improve. Even without any CBT, that alone actually goes a long way.
Absolutely. So the last small topic to discuss is we'll touch on and maybe talk in details in next another episode, is that modern therapeutic challenges, modern counseling challenges that counselors face or psychologists or clinical psychologists face. So they're like definitely it's a broad topic, but at least let's touch the base a bit. So the first one is So I'll just want to touch with you 2 points, and I would love to know your thoughts on that. The first one is that, so let's say a teenager comes in the counseling session as a client, and the teenager had some childhood trauma. At the same time, the therapist can clearly see that the teenager is not responsible in making his own life better. Both are true. The childhood trauma is true. What happened in the early childhood is true, and now he or she is 17 and 18, and his lack of urge to make his or her life better is also true, right? Both are true. Now, if now we see clearly two divisions in the world. I would say division because now it's so clear. One division is you talk about self-love, and you talk about self-love, and you talk about self-love, and you make him feel better. You talk about suffering, and you tell him that your life is not on the right direction because you suffered a lot. Try to get out of the suffering. And the understanding is, if I talk about self-love enough, then he'll get his life straight. That's one approach. But the downside of that approach sometimes is that he or she becomes self-centered and sort of triggers narcissistic traits, which makes him or her more miserable in the long run. In the short run, he's happy, but in the long run, he or she is in despair because he or she becomes lonely because no one wants to deal with someone who's only thinking about self-love. On the other hand, there's another division who talks about responsibility. You know what I mean? Like, whatever happened in the past doesn't matter. You define your life, so take responsibility of everything that happened. Stress can make you strong. Forget about forget about what happened. Just want to take responsibility. Change your context. Change yourself and change your context. And the problem with this approach, or the struggle with this approach, is that sometimes we tend to become victim blamers, in the sense that clients can feel that no one understood their pain. Rather, it feels like I am responsible for the suffering that happened to me as well. A type of victim blaming. Where's the sweet spot? As a psychologist or as a clinical psychologist, where do you think is the sweet spot?
Yeah, very complex problem you're outlining here, right? Between finding that sweet spot, right, is perhaps not always easy. But let me address this question from another angle. So my deep conviction as a mental health practitioner is that if you have experienced childhood trauma, it's never your fault. Children, I strongly believe, especially young children, are always innocent. It's never their fault. And immense suffering comes from terrible parenting and early childhood trauma, early sexual abuse, perhaps in the worst instances. So the damage that is done is never your fault, but it is your responsibility later when you're older to do something about it. For example, to seek therapy and work through that trauma. Now, if you have good therapy, and by good I mean a therapist who has compassion, who understands your suffering and generally authentically understands it, but also has the knowledge and the skills to process what happened to you. So to be trained in trauma-focused CBT or schema-focused therapy, or an appropriate therapy for the childhood abuse or for the problem the client brings.
Right.
If that is the case, I think therapy should broadly, I'm oversimplifying, but broadly focus on two things. First of all, process the trauma so that the client can actually, put the memories into the past. And there's certain, probably we don't have the time not to go there, but it's like, trauma memories are different to normal memories in that they keep intruding. We spoke about OCD. Involuntary thoughts are very common in trauma as well. Sometimes OCD even results from trauma. It's not uncommon. And the thoughts are involuntary, and they often lack the context. So they just float around and they just pop into your mind. And so unlike normal memories, which you can file away and you put a timestamp on it, and you can retrieve them when you want. In therapy, you learn to file those memories away so they don't bother you anymore. That's the first thing. And then the second thing is to develop healthier ways of, dealing with what happened. So if you, for example, drink a lot of alcohol, or if you engage in, say, unhelpful, promiscuous behaviors, or gambling, or other behaviors that have the function of numbing you and distracting you and avoiding you, basically stopping you from processing, you can tackle those too. And if the other maintaining factors are more to do how you relate to other people, for example, if you bully people to feel more in control, you can learn not to do that, and so on. So you need to first process what happened, and then you need to focus on, okay, forward-looking, what do I now need to do to get my life in order? And I don't think, if you have the right therapist, that you should overindulge in self-love and thereby become narcissistic. That may happen sometimes, but I think if you have the right therapist who helps you to develop self-compassion, not at the expense of others. So I think what you referred to earlier was like me first, and I have suffered now, and now it's my time, and I come first, and I focus on my needs. Of course, you need to, as an adult, you balance your own needs with the needs of your loved ones around you. And that is something a good therapist would pay attention to. So I'm slightly dodging that question, but my answer is, if the therapist has an understanding of how to process trauma and help you to develop true self-compassion that is not at the expense of other people, and to help you and reflect it back to you. If the therapist sees that the person becomes very egoistic and becomes narcissistic, then it's the therapist's job to bring this up in therapy and share this in a safe way and say, I'm noticing you've gone a little bit overboard, or I'm noticing the way you're speaking to me doesn't feel so nice, and let's look at how helpful that behavior is.
Yeah, I really think that it's a matter of balancing between self-love and self-responsibility. At the end of it all, we need both, and it's a sound therapist's job to bring both on the table in the most appropriate way. Yeah. So the last question before we end today's discussion is that, in a small way, where do you think that in modern day counseling, suggestions come in, right? In the old days, it was always suggestions, a psychologist never gives any suggestion, never gives any direction. And definitely there are clear reasons why it was done, because, the therapist fundamentally doesn't want to solve the problem. Rather, the therapist wants the client to become the problem solver, right? So that part is clearly there. But at the same time, in modern days, there are complex cases of domestic abuse, domestic violence, and you have an inferior patient who's blaming everything on themselves, where our wife is beaten up really badly and blaming themselves for everything that happened, or terrible cases where even sometimes a legal action is legal aspects come in sometimes along with the therapy. Definitely that's done by the authorities, but safe home and all of those discussions come in. Sometimes there are addiction cases where the client justifies things. So where do you think, definitely we can all agree that in generally the thumb rule is by default, the regular thumb rule is that the psychologist doesn't give any suggestions. I get that. We all agree to that. But there are those complex critical cases where there are disagreements even among the big scholars of psychology. What's your opinion on that?
Yeah. I'm fully aligned with you that if there's danger to the patient, such as there's an ongoing abusive relationship, or say the perpetrator lives next door, in those instances where there's real harm occurring, and perhaps it's difficult for the client to reach that conclusion on their own by themselves. I think it's the therapist's duty to be more directive and to make clear suggestions to keep the patient safe. I actually think it also depends a bit on the treatment modality the therapist practices, right? So in cognitive behavioral therapy, which is the most common form of psychological treatment that has the best evidence base for, especially for mental health problems, the most common ones, anxiety, depression, post-traumatic stress, and OCD we spoke about, or even body image problems. Yes, we engage in what we call Socratic dialogues, where we want the client to reach, I put this in quotation mark, the right conclusion, such as not to engage in rituals and not to engage in any behaviors that maintain the anxiety or depression. But the truth is that I think therapists, they also need to adapt their style, especially if clients are a bit older or they work maybe culturally, they expect the professional to be more directive. I think you can adapt in that sense, and therapists should adapt according to the needs of the client and be more directive when the therapist thinks they need to be more directive, basically. But CBT is a little bit more prescriptive because it tells you, stop the safety behaviors, stop the compulsive behaviors.
There is a definite aspect of dispute in CBT. You know what I mean? Like there is definitely there. So there is thought challenge. I mean, in old day psychoanalysis, it was just like standing in front of the mirror. It was very passive, and CBT is more client centric.
Exactly. Yeah. But I'm a great believer that psychodynamic therapy has a very important role to play in modern mental health. But we need to follow the evidence base. And for depression, for example, psychodynamic therapy is not recommended because it increases the rumination of the client. It leads to overthinking and it can make things a lot worse.
Right.
So you should also always, have the right therapy for, each problem.
Right.
And CBT goes a very long way, and adapted culturally. And I do think it's okay to be more prescriptive, especially when there's abuse or ongoing danger. I think the therapist must tell, the client to get out of those relationships or to be safe first.
I believe that CBT is sometimes we psychologists don't recognize the fact that CBT and counseling itself is also going through an evolution, right? 30 years back, it was very different from what will it become after 30 years. And it's also a matter of adapting to change. Like the concepts, the pre-assumptions are also changing and changing for good, right? So always holding on to the 40-year-old assumption doesn't help, because things are changing, times are changing. We are learning new things, new data, new research is coming. So overall, I had a fantastic discussion with you, Dr. Oliver. Thank you so much for your time. And I'm really grateful to you. Yeah.
Thank you so much, Yahia.
It's
been a pleasure talking to you and being on your show.
Yeah, thank you. And I really look forward to engage more with Intellect and your research work. So we'll have a fantastic research collaboration, hopefully. Thank you. Take care.
Awesome. Thank you so much. Okay. All the best. Take care.